Great. Well, my name's Beth Coughlin. I'm one of the nurse practitioners with the Department of Medicine at Vanderbilt and the Division of Geriatric Medicine. And I work with Mattie Brady as a colleague. We are contracted with different nursing homes within Middle Tennessee. So I'm primarily clinically oriented and then work on different research studies as well. So excited to talk to you guys today about falls prevention. This specifically is going to focus on falls preventions in nursing facilities, so skilled nursing facilities, long-term care. All right, so we're going to go ahead. All right, I have no financial disclosures in this, as Isaac already mentioned. All right, the objectives of our fall prevention in skilled nursing facilities, we're going to start with an overview of falls here, and then we're going to look at the fall risk factors, and then we'll transition into evidence-based interventions for fall prevention, and then we're going to talk about creating a culture of safety. If you have been in the nursing facility world for a while, most facilities have a fall prevention process in place, right? So our goal of having this discussion with you guys is to hopefully improve the processes already in place, give you ideas for new evidence-based interventions that you can implement at your facilities, and hopefully, get some good takeaway about fall prevention, which we know is a very complex issue for our older adults. Okay. So the mastermind, Benjamin Franklin, an ounce of prevention is worth a pound of cure. So like I said, we work with older adults. If we can work on the front end of really focusing and improving our process around fall prevention, hopefully we will not have to retroactively, have as many falls, and we can focus on reducing them. Okay, so big picture, why do falls matter? We know that almost half of all our 1.6 million residents of U.S. nursing facilities will fall annually. Of those that fall, about a third of them will fall 2 or more times in the same year. We know for our recurrent fallers too, there's increased morbidity in those falls, and there's increased risk of serious related injury. 1 in 10 falls result in a serious related injury, and including those hip fractures that we know. And, with those who have hip fractures, a high risk after that too is death. Some adverse consequences for our residents in the facility include, reduced quality of life we see. Certainly if they suffer a fall, they're going to be more fearful of falling in the future, and may have decreased activity because of that fear. And again, the risk of death and serious injury associated with that. I think another big picture why falls are so important is certainly because they can compromise safety at our facilities. And the adverse consequences of falling for a facility is we know there's a lot of assessment that is required after a fall, but there's also increased level of nursing care that takes place if there is a fall. So looking forward, we know the population over the age of 75 is going to double in the next 20 years. So given the prevalence of falls and their reoccurrence, how can we best approach this, right? How can we manage this complex, nuanced factor that can again affect their safety moving forward? All right. So our outline for our evidence-based interventions are really going to go in this order. We're going to focus on risk stratification. Then we're going to look at gait and balance assessments as well as exercise promotion. Then we'll look at medication review. Then we'll discuss environmental modification, which seems what a lot of people are talking about these days. But I like to say the meat and potatoes, I saved you for last. And these are our multifactorial interventions. These are really going to be our key to fall prevention in the facility setting. Okay, so let's talk about fall risk factors, specifically in our population that reside in facilities. So we're going to look at intrinsic factors, then we're going to look at extrinsic factors. These are going to be our intrinsic are going to be our acute medical condition. So if we get a patient from the hospital who has an infection with subsequent delirium that has poor safety awareness, we're going to know this is an acute medical condition. Looking at the side effects from medications too, we know there's a strong association between different classes of drugs and fall risk. So is there a side effect that is contributing to their risk once we evaluate and do a medication review? Balance, mobility, deconditioning, right? Say a resident comes in and the family relays, like mom she can never get her feet under her with balance. That's going to raise a red flag that we have subsequent impaired balance with a higher risk for falls. Our chronic conditions, there's good evidence that shows a history of stroke, Parkinson's disease, atrial fibrillation, urinary incontinence, all those pose our older adults for a high risk of fall. And then our psychosocial aspects, our behavioral disturbances and unsafe behaviors that require behavior management strategies. So that's more the intrinsic factor. Looking at extrinsic factor, this more involves the environment that can place our older adults at risk. And if I tell a lot of people, when you're here at the facility, you always see a fall prevention board, and a lot of the environmental aspects are really honed in on there. And those include poor lighting, a cluttered room, or a blocked pathway to get to the bathroom. We know those can present hazards. Also, what has been established as kind of falling 101 is no slippers, especially long-term care, right? They provide the most comfort, but the highest risk, of course. So really knowing how to kind of mitigate, making sure family residents are aware. Another factor that poses high risk for falls is our unsafe equipment. So looking at bed, wheelchairs, bedside tables, walkers, are the brakes being checked, right? Is the bed side rails? Is there any impairment in there? What are we looking at that could be a hazard to our older adults? Unsafe personal items, these include if a call light or if a bedside table is not close within reach, right? And so a urinal is across the room and a patient or a resident gets up to get their urinal, or their phone is left on the dresser instead of the bed where they can reach. How can we ensure that that external aspect is being tended to? Okay, so in that same vein, looking at intrinsic versus extrinsic factors, also want to identify the modifiable risk factors for falls as well as the non-modifiable. And our modifiable ones are going to be things that address, things we can change. So those include weakness, imbalance, gait, mobility deficits. They also include polypharmacy. We know if you are taking more than 4 medications a day, that increases your risk of falls. So again, addressing that medication review. We also know that syncope, orthostatic hypotension, can be a modifiable risk factor. I see it more than I would like when we get a resident or patient from the hospital that come to our skilled nursing side, right? And they have a fall, their blood pressure is low. And then we're having to investigate what's the cause of that orthostatic hypotension. Are we getting good data to support that they are having orthostatic blood pressures? Were they dehydrated? Were they eating? Do they have autonomic dysfunction at baseline? Another modifiable factor is looking at sensory deficits. Are our residents wearing their glasses and hearing aids to help them with their mobility capacities? Are we making sure that those are being met and we know what they are? Our non-modifiable risk factors are going to be our age. We know in long-term care, if you're over the age of 80, you're at increased risk of falling. Our history of falls, that's one of the #1 predictors if a recurrent fall may happen, is do they have a history of falls? And a lot of times I really investigate, I say, when I talk to families, has your loved one have falls in the past 6 months? And then have they had them more recently? And that even helps me understand if there's been a change or a rapid decline in their mobility that's causing this change kind of in functioning. Chronic conditions like we talked about before, stroke, Parkinson's, also looking at COPD, AFib, depression, urinary incontinence. And then non-modifiable is if you have permanent sensory loss, so complete vision loss, complete hearing loss. Okay, so I want to give you an example of how complex a lot of our residents and patients are, and how, just again, nuanced identifying high fall risk factors can be. I think I mentioned this before, but a lot of the focus has been on environmental extrinsic factors. And I think the future and continuum of fall prevention is really going to be good insight into those extrinsic factors that place a patient at risk. So here's just an example, and this is a very common individual. 88-year-old female, history of stroke, depression, heart failure, and vascular dementia, suffered a fall at home. She was hospitalized, found to have a non-operative subdural hematoma, and had fluctuating hyperactive delirium requiring antipsychotics. She was then sent to us for further therapy and occupational therapy. So what poses her risk? Well, she's 88. She's over the age of 80. Her history, she's had a history of stroke, depression, heart failure, dementia. What's her functional baseline of that dementia? Does she have insight into her safety awareness? Or does she not have insight of kind of her surroundings? She already suffered a history of a fall. And we know too, she has a history of depression. Is she on antidepressants? Those pose a high risk for fall. Is she on diuretics? That could have her at a high risk for orthostatic hypotension. Those things, also looking at those medications. We then see that she does have fluctuating delirium, hyperactive delirium. And so that's an acute medical condition that poses her at high risk. And then she's requiring antipsychotics, which also has a high association with falls. So a lot of high risk factors with this individual, which kind of should be in my admission to this facility. I would have a long conversation of her high risk for falls. These are very, very concerning ones. Okay, so if I'm a facility and I want to address risk factors, I kind of want to say, okay, if I really want to focus, if I want to really improve our process for fall prevention, what risk factors can I address? And there is good literature out there that balance and mobility, medications, psychological, such as unsafe behaviors, and sensory neuromuscular risk factors have the greatest risk to fall. So if you're going to address anything, it would be looking at these factors. I'm going to say again, falls are multifactorial, right? So they're also going to, some may consist of one of these for the others, but this is just highlighting the highest that pose greater risk for falls. Okay, now we're going to transition kind of into gait, balance, and mobility, how those are addressed in our overall fall prevention. Also, if you've been in the world of nursing facilities, skilled nursing and long-term care, you know that there's a lot of controversy around exercise and assessment. There's pretty robust literature about exercise programs in community dwelling adults. But in the past, there's been some inconsistent findings with exercise, specifically in nursing facilities. We know that residents of nursing facilities have a fall 3 times greater than our community dwelling adults. So we know there certainly is a higher prevalence. So the addressing mobility, gait, and balance remains essential in this setting. So where there's good evidence regarding our fall risk assessment for balance mobility include the tug test, and these are performed by therapy, the time to up and go. It's a pretty simple test with ease of performance. and has a strong association with fall risk. The Berg balance scale, as well as the sit to stand test. From these findings outlining an individual's fall risk, then that guides therapy to create a fall prevention regimen, exercise regimen that includes balance and strength training to improve gait and mobility. Okay, so when looking at exercise programs, there's been a lot of studies that have looked at exercise as a single intervention versus exercise in addition to additional interventions when combined with other ones. So we know that it has had a greater preventative effect on the rate of falls when combined with medication review, staff training, environmental modification. And what these exercise interventions include is a lot of intensity training to improve the balance, gait, and strength. Right, one of a pretty robust program that has shown good evidence in reducing falls is the Sunbeam program. That consisted of individually prescribed progressive resistant training. So it's taking the individual risk assessment regarding gait and mobility, and then also implementing balanced exercises in a group setting for about 50 hours over a 24-hour week period. And then also a maintenance period for about 6 months. So again, there's good evidence that the high level balance and moderate intensity resistant training has been effective in addressing falls. All right, another evidence-based intervention we're going to focus on that I've already alluded to a lot is our medication review. Across all guidelines, medication review is recommended in all settings in regards to reducing fall risk. I think a lot of times the recommendations to evaluate and manage medication varies, especially who assumes that responsibility. You know, is that the clinician who admits the patient, is the pharmacist who oversees the facility? And I would say it's a collaborative approach. Certainly, like that example of the resident who I gave before, you know, I would identify and really highlight these high risk fall factors that could potentially compromise the safety of the patient while they're here. So I think it should be both. I think it should be nursing, the clinician, and the pharmacist. When we look at medications and falls, there has been established fall risk increasing drugs. And these classes are highlighted in the table here. We know that our antidepressants have a high association with risk for falls, along with our benzodiazepines, our antipsychotics, and sedatives and hypnotics. There's good evidence that even doing an antipsychotic taper has significant evidence in reducing falls. So a lot of those GDRs, gradual drug reductions, that we start are validated and substantial in reducing risk. I also noted this earlier, but polypharmacy. We know if our residents are on 4 or more medications, that can increase their risk for falls. So really, again, having that medication review and evaluating if these are all necessary, and are there any that could reduce both the pill burden and reduce their risk for falls. So just to highlight, medication review, highly recommended. And I think having a discussion at your facility too, you know, if this is something that you feel like isn't being done, how can that collaboration occur more intentionally and effectively? How can we make that intervention in the fall prevention program more routine? And I think there continues to need to be resources and tools for clinicians to use. How can we access the Beers list to identify medications that could pose increased risk? Also, you know, the prescribing cascade implies when we put on a medication for a certain symptom, if another symptom arises, is that just an adverse drug reaction to the initial medication, or are they entirely separate? But it is really looking into, are we putting on another medication that is simply a side effect from another medication? And again, I think that is really best approach in a collaborative way with your fall prevention team. Okay. Next fall prevention intervention is environment modification. So this also kind of addresses a lot of those extrinsic factors, fall risk factors that we noted before. So reducing fall risk in the changing environment, kind of like what I said before, making sure light has good visualization to the room, providing a pathway for ambulation for our long-term care patients, making sure we have maintenance checks on all the equipment that we're using, ensuring proper footwear, and making sure that our personal items are within reach. I'm going to review a few intervention tools that have been utilized for the environment, and where these are very helpful is looking at, this is all shared responsibility. So again, if you're looking for facility commitment of how we can all participate in shared responsibility to prevent falls, this is a really good tool. The mnemonic is ask about falls, ask patient to agree, to call for assistance, wait for staff before getting up. S is for secure, look to see if call light and personal items are within reach, and bed and chair are locked, and then keep clear of pathways to and from the bed. This is not just for nursing, this is for nutritional staff, this is for maintenance, this is for environmental services, anyone who enters the room that can make sure this is a priority and make sure, again, we are creating an environment that is safe for our residents. Another intervention tool that has been helpful, and this also communicates to staff that you can put at pretty busy hallways in the bathroom where staff can see and reference, is take a second to check it. That means, again, highlighting call light within reach, tray table within access, bed low, bedside rails up, door open for our high fall risk patients, and walkway clear. And any way to communicate what the goals are of the facility for a safe environment is always helpful. Okay, next. So this is what I said before is our meat and potatoes of our evidence-based fall prevention. So this is where there is very robust literature and what can significantly prevent falls in our residents of nursing facilities. Okay, so we know that a combination of interventions, so we kind of addressed exercise and medication review, environmental modification. So this takes the approach that all those single interventions at a combined effort will have a greater effect at reducing falls than if they're just implemented individually. So now this includes exercise, vision assessment and treatment, and environmental assessment and modification. We also know that some of these may vary based on the preferences of our residents and their caregivers. So certainly these interventions in combination of each other that also are individualized are going to be the most effective. Okay, and what does that look like? How are we going to sit down and develop our fall prevention for our residents? Well, first, it's going to be the step of acknowledging the fall risk factors, right? Kind of like I did at the beginning, looking at these individual aspects, and then from those individual risk factors, making focused interventions. Some of that may take that they're all individualized, being customized. So they're all kind of catered to those risk factors. Partially customized interventions will be if the facility at whole, we're all pushing environmental modification, but then to the individual resident, we're doing specific, we're addressing specific fall risk factors. And that means, again, pertinent to that individual and not the facility at large. We know intervention program that is most affected is implemented by a multidisciplinary team, which we'll get into. I think, yeah. So, oh, and there is good evidence about 21% reduction of number of recurrent fallers in these multifactorial interventions when they're in a combined custom plan of care. All right. I'm going to show you some additional intervention tools that we have in our PDSA packages that we've put out for facilities. This is another intervention both tending to the needs of the patient regarding toileting, and this also addresses nursing care getting to cluster their care. So this is considered targeted toileting. We know a lot of patients impulsively can get up to go to the bathroom without help, fall, given instability. And so this helps to proactively address toileting needs while nursing is already in the room. So how this tool would work is while someone is in the room with a resident, asking if they need to toilet, making note of that, and at the next interval within 2 hours that, you know, whether it's the nurse again, the nursing assistant, or someone else is addressing their toileting needs to prevent kind of that need to get up isolated without utilizing the call light. Another intervention tool included kind of in the multifactorial interventions is our personal care board. So this really highlights a lot of those modifiable risk factors we talked about earlier. How does the resident best ambulate? What do they need? How can they get up out of bed? And do they wear glasses and hearing aids that may not be visible on their bedside table or their bedside tray? So this helps if any, say another nurse from another hall answers a call light and they know what is going to optimize the safety for the individual. Based on this communication board. So ideally, this would be placed above the head of bed, somewhere that's very highly visualized, so that all staff can know what best accommodates a resident. Okay, so what does the research show us for fall prevention? So we know that a large amount of falls can be reduced using the multifactorial approach. And what this really comes down to is a comprehensive falls care assessment and then individualized care planning. And what that entails is once a resident has a fall, what are the processes in place? What are the processes in place that can help guide us to kind of get the whole contextual picture of why that fall occurred? And then once we can identify the reasons, the factors influencing the fall, then we can make a plan going forward and then monitor that response. I do want to say there's no silver bullet for falls, right? But if we are going to focus our time and energy on them, how can we be most efficient and hope for the best outcome? And so this is the best way of really making sure we're evaluating all the factors that go into the context of a particular fall. So looking at your facility's policy, this goes into how does the fall assessment occur? Is there training on how to assess a resident after a fall? Are there particular components that make up the assessment? When is it done? Who takes responsibility for doing that assessment? Is there a thorough investigative framework that helps the details of kind of outline all possibilities that may have played a role in why the fall occurred? And then taking all that information, and this is, usually organized by the fall prevention team, multidisciplinary team, taking the context of why fall occurred, and then making a care plan development and implementing that. So if a patient had an antipsychotic at 9:30, they got up independently to use the bathroom and fell. Okay, we know that they just had an antipsychotic. Let's look at, can we start a gradual drug reduction and looking at, can we slowly taper that? Was their walker steady, or was their walker unsafe, or have some maintenance that needed to go into it? Did they have balancing issues? And so let's get therapy in to reevaluate their balance. All of those being catered and curated into their plan of care. This is a really good delineated care plan, especially, I think a lot of facilities say we need ideas for interventions, right? For those focused interventions. And so this is a tool that gets very specific in regarding a lot of those risk factors that we can manage and implement in the care plan. And this highlights medications, looking at orthostatic hypotension, vision, mobility, and unsafe behavior. And this is something, if your facility is wanting more resources in creating that individual care plan, we would love to partner with you and assist with that. Okay, my favorite quote, I say this a lot: we can't always direct the wind, but we can adjust the sails, by Dolly Parton. I really feel this is so pertinent to falls because, I think when a fall occurs, it can be discouraging, but I think we know if they are going to fall, we're going to have the means and the resources available that we're going to be able to adapt a care plan that will work. And once we implement it, we're going to reassess, right? Is it working? What's the response of the individual? Are they maintaining more safety? Are we seeing an improvement in their quality of life and ability just to function without compromising their safety? Okay. And last leg I really want to emphasize is, how do we develop a culture of safety, which is really the essential aspect of a fall prevention culture. What that entails, looking big picture, when you're looking at your facilities, how do we incorporate strong leadership, and how do we have effective communication from leadership to get buy-in from all team members, right? That everyone exists together to promote the well-being and safety of our residents, especially, when things have been transient in our facilities, when we've had staff changes, when we've had a lot of just changes. How can we readapt and communicate to everyone kind of our commitment to safety? How can we communicate the safety policies in place, right? How can staff know if the wheelchair is broken or the bed doesn't work? And how can they escalate those concerns to staff? That may be really helpful. How can we empower staff to know that everyone's voice is valued in this discussion? Because we know the risk of falls is serious injury and even death. And we don't want that for our loved ones. We don't want that for residents of our facilities. And then also, how is the enforcement of safety policies communicated to supervisors or by supervisors and managers to the staff at large? And just some questions to kind of cultivate and think about the culture of safety at your facilities. Who is the fall champion and the fall program coordinator there? I'm thinking about who really has those skills where they want to be on top of that. They want to have efficiency and focus and work together with a multidisciplinary team. What has worked to empower your facility to implement change regarding a safe environment? Where have you seen those communication techniques best received? How can we reiterate the importance of this, and also the ownership and the shared responsibility that everyone takes in helping reduce falls? What aspect of the multidisciplinary team addressing falls is working at your facility? Who is really helpful? Maybe you have a therapy department that is just so good at assessing for fall risk and they put good care plans in place, but maybe the consistency of doing medication review is not really working. So what can be adjusted? How can you have a commitment from clinicians and other people to say, hey, we really want to focus on this area? Where can we adjust our sails to make it happen? And how does your facility communicate its commitment to safety? How does its team members, its residents, your families know that overall we all want the same thing, a high quality of life and a space to recover well for our residents. And just to reemphasize again, the multidisciplinary team, our role works in fall prevention is to assess those risk factors. We're going to diagnose and then make interventions based on those. We're going to monitor. Let's see how that care plan actually is taking effect. And then if we're not having the result we want, or there's bumps in the roads, let's transition and reassess what's not working, right? And the hope is that this circle works together as everybody is working together. I just want to re-emphasize too, the population that we serve are frail older adults within facilities. You know, these are very complex individuals, you know, and they're not the same. And so that can sometimes be daunting for facilities to really take on this endeavor for fall prevention. But I feel like given that teamwork and that commitment to culture safety, that we really are serving a population that deserves just the best care. And if we can uphold their safety as much as possible, then I think that commitment will carry through for a long time. So what highlights I want you to take kind of from the fall prevention? So number one step is addressing fall risk factors. Kind of like what I said before, there's been a lot of focus on the environmental aspect, which can have some shared responsibility. But I think the continuum of care, where there's a lot of good research developing, is really looking at those intrinsic factors, looking at the chronic conditions, looking at the medications, looking at weakness, balance, and mobility, addressing those. I know, you know, if you see that complexity of fall risk factors, really talking to the families about this, I'm really concerned about all that's going on and their high risk for falls, right? And kind of inching through of what are interventions we can do here and now, and then reassess the residents' response. Another of importance is creating an individualized care plan specific to address those risk factors, right? And again, that takes a thorough review of what could be causing their increased risk. Like I said before, our multifactorial interventions are going to have the most robust effect on reducing falls. So really having that collaborative approach with a multidisciplinary team of how we can do both an exercise program, how we can address vision deficits and hearing deficits, and make sure those are tended to so we can reduce the risk of falls. How we can also work with clinicians addressing high-risk medications that can be further evaluated. And lastly, to uphold an illustrated commitment to a culture of safety, and knowing that, you know, by serving our older adults in this way, we want them to know that they're welcome here, and that, they can know that we are continually adjusting our sails to help reduce falls and ensure their safety. Here are my references if anyone wants to see. And then any questions or anything, Mattie, you want to add in?
Thanks so much, Beth. Love to open it up to questions first, and then just a couple closing remarks. And feel free to either enter them into the chat or unmute with any questions. I will say, so each facility has a representative nurse practitioner, and Beth made reference to several interventions. We, if falls is something that your facility is focusing on in terms of quality improvement in an area that you're really hoping to continue to build, we recognize that these multifactorial intervention plans take lots of steps, and that's kind of our goal in assisting with these QI projects and PDSA cycles, is acknowledging that it can take several kind of steps to build your program up. And so we're here to help guide. The intervention packages that were shared are simply ideas. If there's efforts that y'all currently have in your facilities, that's what we're there to do, is partner alongside and help brainstorm, help implement, help with data collection, whatever you need. That's kind of our process with the nurse practitioners being assigned. So please feel free to reach out with any questions. The recording of this video will also be available on our website, so you can go back and reference it. If there's no other questions, that is it for today. Beth, thank you again for putting together all these resources. We really appreciate it.
Yeah, and that's great. And then thanks so much, Mattie and Beth. And I just disseminated a session evaluation link in the chat. So if you guys could please just take 2 minutes, not even, to fill that out. It's really helpful for our team to better understand these webinars and material and what exactly you guys like. So I'd really appreciate it if you could take the time to do so. And with that, we can end the webinar. Hope everyone has a great day.
Thank you.